Good afternoon, everybody. Welcome to our webinar commemorating World Down Syndrome Day. Today, we gather to celebrate the beautiful diversity and achievements of individuals with Down syndrome, while also raising awareness about the importance of inclusion and acceptance in our communities. World Down Syndrome Day, observed annually on March 21st, serves as a global platform to advocate for the rights, inclusion, and well being of the people with Down syndrome. It's a day to highlight their unique abilities, talents, and contributions to society, emphasizing the value they bring to our world. Throughout this webinar, we will explore various aspects of Down syndrome, from medical advancements to educational opportunities and beyond. We'll hear from experts, individuals with Down syndromes, and their families gaining value insights for forecasting greater understanding and support. So let's come together to celebrate this diversity, promote inclusion, and advocate for the world where everyone, regardless of ability, is embraced and empowered to thrive. And thank you for joining us on this meaningful journey. Let me welcome our speaker. I'm very delighted to welcome Dr. Pavani Upendram, a trailblazer in the field of medical genetics and genetic counseling. Dr. Upendram brings to the table an impressive array of qualifications, experiences, and accolades, making her a formidable presence in the realm of genetics. With over 16 years of experience, dedicated service as a consultant geneticist and genetic counselor, Dr. Upendram's expertise spans across various domains, including clinical, molecular, genetics, cytogenetics, and genomic consulting. Her commitment to excellence is evident through her board certified as senior genetic counselor and her extensive experience in counseling patients on a wide range of genetic issues. Throughout her illustrious career, Dr. Upendram has been recognized for her contributions, earning accolades such as Young Scientist Award from Indian Society of Human Genetics and serving as the elected General Secretary of the Board of Genetic Counseling India. Her passion for research is reflected in her numerous international publications and presentations at various prestigious conferences. Dr. Upendram's dedication extends beyond confines of the clinic and she actively engages in community genetic counseling and awareness programs. So, without further ado, let us extend a warm welcome to Dr. Pavani Upendram. The floor is yours. Over to you, ma'am.
Thank you, Dr. Krishna. Thank you for that introduction. Welcome all. So we are here to talk about, gain awareness about Down syndrome on this World Down Syndrome Day, and also increase the awareness about people who are living with Down syndrome, who need that extra empowerment from all of us to meet their own passions, goals, because they are special. They need our support. So today, our main focus will be on the prenatal and postnatal diagnostic techniques for Down syndrome, and what are the and postnatally. That will be the main focus today. Dr. Krishna, can you please share the PPT?
Yes, ma'am. Sharing. Ma'am, you're good to go.
Yeah. So we'll just start with what we've just discussed. So today is 21st March, World Down Syndrome Day. I remember learning about chromosome 21 as a first. That was the first thing which we have learned as cytogeneticists in the Department of Genetics where I've started. My mentor, Dr. Annie Hassan, has taught us. The first numerical abnormality we were taught was Down syndrome, and from then I over years, and I think I'll be able to add or throw some light on this topic and share my insights with you all. Next slide, please, Krishna. Yeah. So I'll just start with the basics. So this is a simple central dogma which is seen here. We all have, all of us know, most of them are by the people and they're medicos. So I'm sure this is not, there's no need to emphasize much on the genetics aspect of it. But anyway, so this is the cell with a nucleus in it. Only the nucleus has the DNA and also a part of mitochondrial DNA we have. So the nucleus has chromosomes. Basically, the chromosomes are formed with the DNA bound around the histone protein. So the DNA is basically formed with the ATGC base pair. So the genes are bound tightly coiled over the histone proteins, and that's how a chromosome is formed. Chromosomes are like chromosomes. Checking for chromosomes is like checking just the numbers and numbers in a page. Like there are in humans, that number won't change. It is a constant. In normal individuals, 46 chromosomes are seen. So we check for those highly condensed chromosomes in the metaphase state, because in the mitosis, in the cell division, there are 4 stages: prophase, metaphase, anaphase, and telophase. And amongst these 4, metaphase chromosomes are the ones which are super compressed, and we can study them very well in that condensed state. So we are interested in looking at the chromosomes and seeing the abnormality both structurally and numerically in the chromosomes. Next slide, please. So Down syndrome, as we all know, it is an addition of extra chromosome 21 in all the cells or some of the cells, because I'll just come to that in a while. So it is the most prevalent genetic disease worldwide and the commonest genetic cause for intellectual disabilities. And incidence varies in newborns. It is different in different populations. It is around 1 in 400 to 1500 worldwide. This is the most common chromosomal abnormality, and it is found that most frequently, this is the most frequently occurring live born aneuploidy, which is Down syndrome, because it is named after Langdon Down, who has described it in 1866 in Paris. But however, there is evidence that it is discovered thousands of years ago. So the patients typically have facial dysmorphic faces, happy faces. Basically, I should not be calling dysmorphic faces anymore. We're talking about inclusivity, happy faces, mild to moderate intellectual, and also the screening for Down syndrome is an important part of routine prenatal care, because that can be easily picked up during the prenatal course. Next slide, please. Yeah. So this is one important slide where we know, see, for all the students in the webinar, see, this is the basic. And the commonest ones, commonest questions, commonest syndrome is Down syndrome, and even in that there are types: free trisomy 21, translocation Down syndrome, mosaic Down syndrome. Free trisomy is majority of the trisomy 21s we see are free trisomies. That means complete chromosome extra, in addition. And translocation Down syndrome is it comprises a very less percentage of all the Downs cases, where one chromosome, one additional chromosome is sitting on other acrocentric chromosome, which also results in Down syndrome. That is called translocation Down syndrome. And mosaic Down syndrome, this is another very rare presentation amongst the Down syndrome cases. Mosaic means there are certain cells which are normal, 46 chromosomes, and there are certain cells with additional chromosome 21. That is mosaic Down syndrome. Next slide, please. See, I will be showing you the images and I'll be explaining you. Hope that will be interesting. See, the first one, where there are complete 3 chromosomes, 3 short chromosomes, 21 chromosomes, and that results in free trisomy 21. This is caused because of the non-disjunction, meiotic non-disjunction, where during the meiosis, there is meiotic non-disjunction. Division in the gametes, the chromosomal division in the gametes happens it is not even where all the gametes have equal number of chromosomes. Like we all know all the somatic cells have 46 chromosomes, but the germ cells have only one set, haploid set of chromosomes. So in that, sometimes during meiotic non, in meiosis repair, in the DNA repair mechanism, they can be one. Some can have additional 21 chromosome and some without 21 chromosome. That's how a free trisomy happens. And whereas the translocation, if you can see, this is one illustration. I'll come to a proper karyotype in my next slide. You can see the number 14 seen here in the green is, no, can you please go back? Yeah, maybe I can show you here. See the first one. Yeah. So in this, the 14th chromosome has chromosome 21 above it. This is both are acrocentric chromosomes, for your information. Centric chromosomes are the chromosomes where the P arm is very much condensed and it is almost negligible. So chromosome 21 is an acrocentric chromosome and it goes and sits on the top of chromosome 14, which is another acrocentric chromosome. That is a translocation, which is known as Robertsonian translocation. And this is mosaicism. The pink one is mosaicism, wherein you see there are two types. Two 21s are there, and the other one is 321 chromosomes, which again is an example of mosaic Down syndrome type. Next slide, please. Yeah, this one. See, I'm happy to say that these are from my team. We do these. We are into cytogenetics. We do day in and day out karyos, and these are the beautiful chromosomes of our own samples. See, the first one is chromosome 21 free trisomy, three different separate chromosome 21s. And when you come to the next image, you see it's a Robertsonian translocation where it is just a Robertsonian translocation and not a Downs, because this is a carrier. I'll explain you that again in a while. See here, one chromosome 21 is missing, which is sitting on top of chromosome 40. Next slide, please. Here, this is another Robertsonian translocation where both the chromosome 21s are sitting on chromosome 14. Again, this is a carrier one. But the fourth image which you see here, it is 46XX with a derivative. There are two 21 chromosomes on one on each. I mean, it is a kind of isochromosome. There are two, not exactly iso, where both the P arms are added. So this is again a type of Down syndrome where two 21 chromosomes are attached to each other. So totally in this karyotype, there are three copies of chromosome 21. Next slide, please. So like I've just explained, this is caused by the errors in cell division, which is non-disjunction. So this is the most commonest one, but like I said, a small percentage would comprise of the translocation also, but there is high likelihood of high chance of recurrence. Recurrence risk is high in these Robertsonian cases because the parents are carriers. They have that translocation, like you have seen in the earlier carriers where I've shown earlier karyotypes. So they are most likely to pass on one chromosome, which is a translocated one. And from the other partner, there is a chance another chromosome 21 will come. This will lead in aneuploidies. Mostly, if there is a gain, it is trisomy. If there is a loss, it is monosomy. Monosomies tend to abort spontaneously. They won't progress. Also, in this, in the mosaicism, like I said, there are two different cell lines, and these are the Down syndrome individuals who may have milder presentation based on the level of mosaicism and the gene expression. Next slide, please. So again, I'm coming back to incidence where it is very much varied based on the populations, and it is very surprising to see high incidence despite the advanced testing methods, screening and testing methods in our country. So like we said, like I've emphasized already, the highest percentage of abortions are because of Down syndrome. So mostly 50 to 75% are lost before term because of the aneuploidies. However, most common live borns are trisomy 21. There are other trisomies which are Patau's, Edwards. They are not. I mean, that may be because of the net genetic content on the chromosomes, because 21 chromosome being the smallest one has small number of genes. So maybe that's the reason. So it has very less genes which are involved in the pathophysiology. So maybe that's the reason. There are many live borns, though this is the most common cause for the early abortions and the aneuploidies. This accounts for most of the aneuploidies. This the only Down syndrome is the most commonest live born aneuploidy ones. So next slide, please. So coming to the presentation, clinical features, and I'm sure majority of us, whoever have basic genetic background, can pick up the clinical presentations of an individual with Down syndrome. They have a very happy face, flat face, small head, short neck, protruding tongue. They have palpebral fissures, and also they're weak. They're poor muscle tone, and they're short. The stature is short for them, and they have brush feet spots, and also coming to the major congenital malformations which are associated with Down syndrome, the duodenal and esophageal atresias are the commonest, and also the septal defects, cardiac issues are the ones. Septal defects are most common. Hypothyroidism is also very much common in these individuals. They may have vision, hearing issues, also sleep apneas, and immune. They may also have immune disorders, and also they have cognitive issues, and they have intellectual disability, but it varies from individual to individual. It is not common across all Downs. Next slide, please. Okay, now we know that Down syndrome are the most commonest live borns. So there is a high chance that a woman can deliver a child with Down syndrome. Not all will get aborted in the early trimester. So there are very well established pre and postnatal screening and diagnostic methods which help us identify trisomy 21 beforehand. So prenatally, it can be detected. There are screening methods. We're talking about the definitive diagnostic methods here in this slide. There are karyotype, fluorescent in situ hybridization, qPCR, DNA microarray, obtained from either CVS, chorionic villi sampling, amniocentesis, or codosynthesis. Coming to the postnatal, where we are testing after birth. So it is classically presented, so clinically it can be established, but however, the genetic confirmation is mandatory, so it is done by karyotyping, FISH, or chromosomal microarray. So this is just a phase which shows Down syndrome child. So prenatal screening, no, it's okay, please. Next slide, please. Prenatal screening test. Now, I will talk about the definitive. There is a difference between a screening test and a diagnostic test. Screening tests are the ones which give the risk and not confirm the diagnosis. Diagnostic tests are the ones which are very much definitive, we know, and each diagnostic test has its own sensitivity and specificity, the negative predictive value and positive predictive value. So coming to the screening test, they are often they often come as a group of tests, like an NT scan, which is done after the viability scan at around 10 to 12 weeks. Nowadays, there's early TIFO also. So NT scan checks for the nuchal translucency. So then also in early TIFA, nasal bone is checked. Absent nasal bone is an indication. Short female length is seen. Also, in addition to this, to increase the sensitivity of the screening programs, the double marker, the biochemical marker tests are readily available. There are guidelines which test to be done, when to be done. Double marker, triple marker, and quadruple marker. All these tests are biochemical tests where the mother's blood is collected to check the certain hormone levels. Certain levels in mother's blood indicate a high risk for certain condition. Not only for Down syndrome, there are other indications also for spinal defects and placental insufficiency. There are many markers, but remember, these are all screening tests and not definitive tests. So there are a combination of tests which are conducted and which have reasonably good sensitivity and specificity and all these. But despite all these, it is not the Down syndrome can be picked up or the trisomy 21 can be picked up with all these. This is just an indication. So again, almost 70 to 80% of the screen positive women come negative for amniocentesis. This is what we see these days. I mean, the cases which we get, prenatal cases with high risk of double marker high risk, triple marker high risk, and any of these soft markers, amniotic fluid karyotyping turns out to be normal. And surprisingly, all the prenatal screenings will be normal. We see individuals, women coming with their children for karyotyping, and they turn out to be Downs. And when we go back retrospectively, check their markers, screenings, antenatal checkups, everything will be normal, absolutely normal. So here we will, here the role of screening tests and this sensitivity comes into place. So that's why there is another additional highly sensitive non-invasive prenatal screening test, which is genetic based. All these other tests are like either the ultrasound test or the blood tests which are run on maternal blood, checking maternal hormones. But this non-invasive prenatal screen, we used to call it, was named as non-invasive prenatal testing earlier. But now this is also a screening test, but with more sensitivity, which is close to 99.99% for trisomy 21. For other aneuploidies, it is slightly lower, like 98%, 92%. But for trisomy 21, NIPS has highest sensitivity. Next slide, please. Yeah. So this is a slide which shows what NIPS means. What do we do? Non-invasive prenatal screening means we are not doing any invasive test. This is again done using maternal blood, but we collect the maternal blood after a time period, after a gestational age, which is after 10 weeks. It is ideally after 12 weeks, just to see the fetal fraction. Because see, the main principle behind NIPS is getting the cell. If you see in this image, you can see the blue ones are maternal DNA, which is common. A mother's DNA, circulating fragments of DNA are being circulated in mother's blood. And after 10th week, the babies, the fetuses, DNA is also in the bloodstream. So we take the maternal blood, see what fraction of fetal DNA is there, cell-free fetal DNA is available, and there is a cutoff. 5% is a cutoff, so we should definitely have 5% of fetal fraction to proceed with the test. So obtaining this from the maternal blood, the test is performed. Again, this is performed at a gene level and not a biochemical level. This is a gene level, so wherein we are checking for the trisomy 21 copies, the copies of chromosome 21. So again, the maternal blood, 20 ml of maternal blood is collected in Streck tubes, and there is a very well standardized method, validated method. There are many companies which offer NIPS these days, very, like I said, with a very good sensitivity. So it picks up mostly the trisomy 21s. So this is one of the advanced screening tests. Next slide, please. Okay, now we are coming. So these are the screening tests which I was talking about. Now the prenatal diagnostic tests. Diagnostic tests are confirmatory tests. So now let us think that there is a case which is positive with a screen, and maybe NT, high NT, or positive for screen positive, double marker or quadruple marker. So there is a way to check and confirm the screen finding. So always, even the NIPS, which is very sensitive, has to be confirmed with the diagnostic test. Coming to the confirmatory prenatal diagnostic tests, these are either chorionic villi sampling, amniocentesis, or which is now called percutaneous umbilical blood sampling. So now CVS is again all in all these samples. There are 3 to 4 tests which can be run to identify whether the sample has, which is showing high risk in the screening test, has additional chromosome 21 or not. Not only chromosome 21, for any aneuploidies, these tests remain the same. So next slide, please. This is a standard slide which we use from the American College of Obstetricians and Gynecologists. They have set timelines where when to do, which test to do, double marker, triple marker, and they also highly recommend adding NIPS to the screening protocol to increase the sensitivity and help the individuals who want to know the actual risk. Okay, this again explains, I'll be explaining in detail in the next slide. So we will talk about chorionic villi sampling, which is again done at 10 to 13 weeks. All these three are invasive procedures where mother is undergoing an invasive procedure where a fetal medicine specialist or a trained radiologist is doing the procedure under proper ultrasound guidance to get either the chorionic villi, which are from the placenta, which are also from the baby. So the villi are collected. This is very early. This CVS, the ideal time to do CVS is around 10 to 13 weeks. And this is also this is also a testing material to know what the chromosomes are or the gene copies by whichever method. Coming to amniocentesis, this is done after 16 weeks and before 19 weeks, where it is ideal to do. Can you please pass on to the next, move to the next slide? I think I have the images there and I'll talk. Yeah. See, this is CVS. This was what I was talking about. Villi are obtained in CVS test. This is done at 10 to 13 weeks to collect the villi, and then the same test will be done. Move to the next slide. There's another method by which any aneuploidy can be detected is amniocentesis. This is one of the safest methods for testing, doing the diagnostic test prenatally, wherein we just collect, the radiologist or the fetal medicine specialist collects only the amniotic fluid, 10 to 20 ml, ideally 15 to 20 ml of the fluid is collected, ideally between 16 to 18 weeks, where the fluid is apt, and even if we collect 20 ml of the fluid, the pregnant woman can regain it within 24 hours of time with proper rest and hydration. So there's no risk, and there is 1% of miscarriage risk in amniocentesis, which is very less. And when compared to the three methods, amniocentesis is the safest one. And this is the most common practice which is done, amniocentesis. And in some cases where there is no time and the time is of major concern, CVS can still be done with the villi sampling. Please move to the next slide. This is another method, diagnostic method, which is an invasive method, where the sample is collected from the cord, umbilical cord. Again, in this there is a high chance of maternal cell contamination also, because the triple vessel it needs so much of expertise. And this is also again another way to collect the sample and proceed with the testing to check for aneuploidies. However, amniocentesis is known to be the most safest one to check for the aneuploidies. So next slide, please. Now we get the sample. We get either villi, we get either fluid or cord blood. Now what do we do? How do we do it? There are methods to detect postnatally or prenatally. There's another method which is the QFPCR also, which helps in detection. So here comes the postnatal method. Postnatally, now the child is born. There are queries, ASD, BSD, phases, dysmorphic phases, query down. So what do we do? There are the methods which are employed are karyotyping, fluorescent in situ hybridization technique, and chromosome microarray. analysis. Next slide, please. So this is classic karyotyping, which most of us know. In this, an individual's blood sample is taken, cultured for almost 72 hours, and then the cells, all the lymphocytes are arrested at metaphase using certain chemicals, and then fixed. Those cells are fixed and dropped onto a slide, glass slide, and stained using standard banding techniques, which is GTG, Ginsa-Trypsin Gimsa banding techniques, and the chromosomes are arranged. An expert does the arrangement of chromosomes and picking up the abnormalities, be it structural or numerical. So generally, all of us, this is the basic information where all of us have 23 pairs of chromosomes, in which 22 are autosomes and one pair is comprises of the sex chromosomes or allosomes. Okay, next slide. So this is a metaphase. This is how a metaphase looks. Is after the cell preparation is done and after the staining is done, this is how a chromosome metaphase, like 46 chromosomes which are arranged into groups. There is a classification system. ISCN has a classification system with which we arrange them based on the banding pattern. So this is a normal 46XY karyotype. Next slide, please. Here, this is Down syndrome, free trisomy Down syndrome, wherein 3 separate chromosome 21s are seen, and the other one is Robertsonian Down syndrome. Here you can see it is 46. In this karyotype, the number of chromosomes is 46. However, if you see, there are 2 21s under 21 chromosome group, G group. But if you see the 14th chromosome, there is another chromosome 21 sitting on the chromosome 14. This is a Robertsonian Down syndrome. This is what I was talking about when we were initially discussing about the types of Down syndrome. Next slide, please. Fish. Okay, fish is another technique which has equally good sensitivity to detect postnatally. Even prenatally, fish is used. Postnatally, less implications when it comes to trisomy 21 because adequate sample is available in postnatal cases. So we run a karyotype basically. But if there is a shortage of sample and if there are any concerns, it is mostly the implications are in prenatal samples where there are very less amniocytes, and we do fish to give a quick result. But again, the sensitivity is not very as high as the cytogenetic, the karyotype test. So in this method, there are fluorescent labeled probes for a particular, for our region of interest. In this case, it is chromosome 21. So the chromosome 21 probes are added and they are visualized to the metaphase plate, metaphase or cells, which I've just shown. We add the probe and hybridize it. Next slide, and visualize using the counter stain under a fluorescent microscope. So it has good sensitivity, but like I said, for postnatal samples, karyotype is the best. Next slide, please. I'll show you the images, how a fish look like. See, first image is of a postnatal sample, first image, wherein you see completely well spread chromosomes with 13, 18, 21. And the second one is an amniocyte with amniocytes. When we collect the 20 ml of amniotic fluid collected will be processed for fish in certain cases. If the clinician want to get the testing done quickly within 5 days, so they give for uncultured amniocyte fish testing, where you see these are the uncultured amniocytes. You see clear 2, 2, 2 for each. The common live-born trisomies are 13, 18, 21. That's the reason we check for 13, 18, 21 most commonly. The next one is a positive fish cell, the amniocyte for trisomy 21. You can see the 3 red signals which indicate 3 chromosome 21s. Okay, next slide, please. Coming to CMA. CMA is another advanced genomic method, chromosome microarray analysis. It is used to detect the low level changes, structural changes like the micro deletions and duplications, which are not visible because karyotype cannot pick up anything which is below 10 kb. So karyotype sensitivity ends there. So if there are many micro deletion duplication syndromes like Day-George syndrome, there are many, Prader-Willi syndrome, Angelman syndrome. So for those, chromosome microarray is the best method to because it has high sensitivity to detect for a change which is as small as 5 kb. So this test is used, and also this test can be used to detect chromosomal aneuploidies. However, CMA cannot detect balanced translocation. So, for an individual who has a query for Down syndrome, this can be used because it should be some additional material or loss of material, but not a balanced translocation. See, if you run this, run a sample from a parent who is a carrier through CMA, you don't get anything because their net content, the genetic material is same. Whether this 21 chromosome is sitting on 14 or any other 15, the net content is same. So it cannot. The drawbacks of CMA is it cannot detect the balanced translocations. So for determining the carrier status in the couples, karyotype is a gold standard. Next slide, please. Yeah. Now this is one interesting case which I would like to discuss, which indicates the importance of the advanced both karyotype and chromosomal microarray testing. So this is a case which is known to us from a long time. So we have a very good follow-up for this. The proband has approached us 4 years back when he was married with his first wife. They've they had one child, one male child, and they had some issues. They got separated, but the child who was born was alive for almost 22 days with multiple complications and dysmorphic faces, wherein the sample was sent for testing. We could see the sample was suboptimal because of the multiple infections he has, because of the medication he was having during that time. So we couldn't get good. At that point in time, we have just stored the cells, DNA, and we couldn't do much. We have explained the same. So next, he remarries and he comes back to us with one early miscarriage, and then one pregnancy wherein everything was fine till 12 weeks, and suddenly at 12 weeks there's no heartbeat. So again, when I discussed with the gynecologist, we by then I we wanted to test the couple, the wife and the husband, and then we parallelly asked for a POC sample, so products of conception. I spoke to the gynecologist; she was very much helpful. So she had sent from a very far place. We got the products of conception, and we had run the samples. So also interestingly, in this pedigree, you see a strong family history of neonate deaths with dysmorphic faces, but this is what the information we've got from the proband and his mother, and nothing much. We managed to see one photo of the proband's maternal uncle who recently died, who had dysmorphic faces. He looks dysmorphic, but it is not classic Downs. So we had again. So now, can you please move to the next slide? Here. This is the report of the proband. So when we had sent the products for products of conception, and we didn't even get the results yet, so we found a translocation, balanced translocation between chromosome 21 and 8. See, if you can appreciate the last segment, distal segment of chromosome 21 is sitting on chromosome 8. This is the proband. So he is a carrier for the translocation. This is a balanced translocation. That is the reason the individual, the proband is normal. He has no issue with the bad obstetric history to his wives. Next slide, please. Subsequently, we got the chromosome microarray result of the products of conception, and with the family history we managed to get the proband's mother sample also. If you see, it is now very well established that the mother also has the same balanced translocation between chromosomes 8 and 21, and onto the left you see the microarray early showing a duplication on chromosome 21 and deletion of chromosome 8, which is an unbalanced one. So, and we have also given the first child who had issues and died immediately afterward during his postnatal period. So his sample also showed the similar unbalanced translocation. So this case is a classic case to explain about the importance of cytogenetic tests and the workup required for couples who have RPL. See, Downs again, we can if we go back and see the proband's maternal uncle, now he must be a partial Downs because of the partial duplication of chromosome 21 and normal 8. That may be the reason he is live born. So this explains the case, and this explains the importance of cytogenetics in picking up the trisomy or aneuploidy detection in both prenatally and postnatally. Please, next slide. So again, so we have discussed about everything regarding Down syndrome. Our role being geneticists, medical geneticists, clinical geneticists, and genetic counselors, we should explain them how important it is to check and what are the options available. And it should always be, the counseling should always be non-directive. We should explain them how it is, and if they're willing to continue the pregnancy, it is on us to extend them the complete support, help them with the support groups. We advocate for them and help them postnatally immediately regarding hypothyroidism, cardiac defects, and the gastrointestinal issues. All this, it is our job being geneticists and genetic counselors to explain them what are the possible outcomes and what management options are available if they decide to continue the pregnancy. Because in my experience, we have seen so many individuals, so many couples who have decided, despite knowing, they would just like to know their risk. Yes, what is there in the fetus, the aneuploidy status. They have continued and delivered, and they're happy with their children or child with aneuploidy, additional 21. So we have to give them the support which they need and explain them what are the management options, and because they need support. So all that has to be explained by us. So next slide, please. Okay. So there is no stand like all other genetic conditions. There is no straight therapeutic option or treatment option for Down syndrome, but it is based on the presentation. If not every Down syndrome, free trisomy syndrome individual is same. So it is independent of each individual. It is not, even if it is free trisomy, it is different from case to case. Some may have very mild presentation, some may have severe presentation, and some may need much surgical attention regarding their tracheias, and the cardiac corrections are required. Some may not need anything, and we know individuals who are doing excellent job, who are on their own, and in fact helping the old parents of theirs despite having additional chromosome 21. They are special, yes, they need special care, but they're really special in every other aspect, because we today I've seen from morning, I've seen so many status messages of my colleagues and friends where all they were putting up all the Down syndrome individuals who are excelling in their own fields. So it is very happy to see that, and all of us have a role to play in this, to extend our support by helping them to know what are the screening checks, what are the diagnostic tests they need. Like for hypothyroidism, they have to do once in 6 months thyroid checkup, the basic ones, and we have to explain them. It is on us to let them know and give that information. Next slide, please. Yeah. So they need special therapies, physical, speech, occupational. They may need assistive devices, wherein the keyboard, like all these are nowadays are very easy to get. And we have seen individuals, Down syndrome individuals, who are on this, and they're doing very well. They may need prescription, because to correct the thyroid abnormalities, they need medications and surgery for any septal defects or the gastrointestinal issues. Surgery may be required. Next slide, please. Yeah, I think we are. Yes. So I also today, I think I'm not very much digital person, so but I've seen so much today on Instagram and my WhatsApp, end the stereotypes. Yes, we also add to this, end the stereotype. Yes, every minute one baby is born with Down syndrome in India. I just saw this morning, so I thought I'll add this. So maternal screening, key step is prenatal care to ensure healthy tomorrow. Yes, with all this, if a couple decides to deliver a Down syndrome child, yes, we all should be there to support them and empower them and give the due respect they need. Thank you. So I think we're done. So any questions?
Thank you so much, ma'am. It's been a insightful presentation. You just illuminated from the diagnostic approaches to management options and intricacies of utilizing advanced fish techniques that you just with those things you just made a remarkable depth clarity within us, and by shedding light on those crucial aspects you undoubtedly enriched our knowledge and empowered us. It was a great session, ma'am, and we have a lot of things that how can the diagnostic approaches are from different to different, and you just clarified with an in detailed thing. We are very thankful, and those clear presentations and the things helped us a lot. Thank you so much, ma'am. And now we are open for
Thank you.
Q&A session. uh, is it okay, ma'am? Can we open up for
Yes,
Q&A?
please. Yes, yes, yes.
Yeah, yeah. So please raise the hands if somebody have any doubts. Then we'll definitely uh, make you to speak. And ma'am, I think yeah. Question is.
Do we have some questions, Dr. Krishna? I think someone has raised their hand.
Yeah, yes, ma'am. Yes, ma'am. You're just in a process of unmuting.
Hello, ma'am.
Hello.
Thank you, ma'am. That was very insightful. And I have a question for you that are partial Down syndrome and full Down syndrome are same?
No, partial Downs is like I've discussed in the. They're not same, dear. They are different because only a part of chromosome 21, like in the case discussion I've done, only part of chromosome 21 is missing there. So it depends on the number of genes. I mean, the genes missing and the amount of DNA missing chromosome 21, which explains how different they are. Free trisomy is classic trisomy. They may have full blown down presentation, but partial downs it may be because of the mosaic presentation, wherein some cells have downs trisomy 21 and some have complete normal 21s, two 21s. So they.
Thank you, ma'am.
Ma'am, can I ask a question?
Yes, please, Dr. Krishna.
Yeah, according to my knowledge, that the major reason behind Down syndrome that old maternal age is one of the major factor. That maternal age over 30s, and late marriages are the responsible for the Down syndrome babies. But we have seen a couple of cases. Just the mother is just 21 years old and 23 to 24 years old. Is there anything that has been changed for the reason behind young women getting Down syndrome babies?
See, I think, to my knowledge, it is all. I mean, it was that was a theory which we all have studied. Advanced maternal age, yes, more aneuploidies because the repair mechanism fails, and that's why aneuploidies happen because the meiotic non-disjunction is more common in advanced women with advanced maternal age. But now, this picture has completely changed. Practically, we see in a month, if we do 30 if we report 30 downs cases in a huge setup, we get almost close to 60% of that, whatever number it is, we get the mothers are of just 20 or 25 years age. I actually, that was really an interesting question, Dr. Krishna, because I wanted to emphasize on that too, but somehow I just missed that. Good that you've asked. See, nowadays that whatever we have learned, it doesn't matter whether a woman is above 35 years or 25 years, screening is mandatory. Because we see so many women delivering Down syndrome children with absolute normal antenatal tests, everything normal, and they deliver a Down syndrome child. So I think this is because the reason could be again because of our environmental exposure and the DNA failure of DNA repair mechanism is what I feel. There may be so much to this which the researchers and the experts would like to add, but I think yes, nowadays it is not. It has got nothing to do with advanced maternal age. Every woman who is pregnant should go through the screening protocol to know her risk, especially the ones which, especially the screening tests which have high sensitivity. I recommend NIPS for all pregnant women because the sensitivity is high, at least for trisomy 21, which is most commonest live born things. If it's adverse or pataus, they're known to get aborted spontaneously, and they early life deaths are seen. But Downs, they are the live born. So if we have to know the actual risk, then highly sensitive screening should be recommended to every pregnant woman irrespective of her age.
Thank you, ma'am. That's as you mentioned. Yes, the theory is what we have studied has been changing from day to day. And as you mentioned, my policies have been updated. Then it will be very fine for mandatory NIPT tests. And then, ma'am, we have a question from Parichay SR from a Q&A chat box. He's asking that NIPT being 95% sensitive for T21, we have seen some of clinicians taking MTP decisions. Based on this, your thoughts?
No, I would like to correct the sensitivity percentage because to my knowledge, it is more than 99%, whichever labs test it is, because there are certain labs which they have validated in-house. So the sensitivity for T21 is very high. Despite the high sensitivity, I repeat, it is just a screening test and not a confirmatory test. It has to be confirmed by a diagnostic test, be it QFPCR, be it ideally karyotyping, and then the medical decision has to be taken. No, there are guidelines also. I mean, if that is being practiced, I think it is just not correct. I don't have anything more to add, but it should not be that way. It should be only after a confirmatory test, positive confirmatory test, that a clinical decision has to be taken.
Got it, ma'am. Got it. And there are a couple of questions raised from the audience. I'll let them unmute.
Hi, madam.
Hi.
My question is that nowadays people are suffering from fertility problems due to unicorn uterus or biunicorn, and they are going for a treatment like IVF or IUI. Is there any chances of getting Down syndrome baby through these treatments?
I don't think it is because of that, Randy. There is no evidence for that statement, actually. I've heard from few gynecologists also. A few gynecologists have asked me about that, but no, that should not be the cause technically for Down syndrome.
Thank you very much.
The next question, please.
Hi, ma'am. Is NIPT is an alternative to amniotic fluid karyotyping?
I think I've just answered, but I'll tell you. It is just a screening test. However, how much ever we promote, it is just a good screening test, but not a confirmatory test. It can never replace amniotic fluid testing. If it is positive, if NIPS is positive, it has to be confirmed by amniotic fluid testing or CVS testing. It has to be confirmed by a diagnostic test.
Thank you, ma'am.
Okay.
Ma'am, we have a question from chat box, Q&A. Yeah. My sister baby has Down syndrome. Does my children will get or not?
See, first of all, we have to see whether your sister's baby karyotype is done or not. If it is done and if it is free trisomy, then it is most unlikely that your sister is a carrier and you are a carrier for any balanced translocation. If your sister's baby's karyotype shows any Robertsonian Downs, then yes, your sister should be checked first, and then maybe you do a karyotype and see what your karyotype status is, and then we'll know your risk.
Got it, ma'am. Understood. Any questions from the audience?
Good afternoon, ma'am. I have a question for you. So, which non-invasive method is most preferred for prenatal testing?
Sorry, I am unable to hear you.
Which non-invasive method is most preferred for prenatal testing?
NIPS.
Why?
Because of its sensitivity and because of the methodology, because the cell-free fetal DNA is tested here. So it is more sensitive and specific when it comes to the chromosomal copy number.
Thank you, ma'am.
We have one more question from Q&A, folks. Hi, ma'am. What if one of the twin baby is affected with Down syndrome? Then how about the chances of the second baby to be normal?
You mean if it is, what do you mean by affected? Whether it is confirmed or confirmed on only twin one, or usually what happens if it is screen positive, then both the if they're dizygotic and dichorionic, both the samples are sent for testing, and we'll know which twin has and which twin doesn't. So we'll give the report like that. We will very clearly get fluids from two sacs. And we'll know, we culture them separately and we'll know. Yeah.
Hi, ma'am. Ma'am, in your experience, how many cases have you seen that NIPT it's turned out to be negative, but birth of a Down syndrome baby? Has it ever happened?
I've seen. Yes, it has happened. I think I've seen 4 to 5 cases.
How do we handle?
I've done close to 500. I've done close to 500, but I've seen 4 to 5. Yes.
How do we handle the couple parents in cases like that? Since we say that NIPT is 99% sensitive and the baby is already born with the Down syndrome. Correct.
See, that again comes back to the question about the testing laboratory where the test is being done and the person reporting it. All these are taken into account because we see the reports from different labs and and everything else is normal, and this happens. Now we have to answer them about how it happened. It can still happen because we know it is not 100% sensitive. It is, again, that is the reason we say, I reiterate, it is a screening test. Yes, so we cannot do anything if it is negative, NIPS negative, and all the other markers are absolutely fine, and then.
Thank you.
It is very tough. It is very tough to counsel the couple with this because they come back to us with the baby and the reports, because everything else will be normal. We know we have I recommend this, and it is normal. They get it done elsewhere. They get the repeat done. Both are normal. I've seen one case where 2 NIPS were normal with 2 different labs, and still this happening. This is one of the cases. 4 out of the 4. So it is very tough to counsel the couple, but yes, we'll have to explain about the technical limitations in this case, in such cases. And that's it.
Got it, ma'am. Thank you, Hepzibah, for an extraordinary question. Yes, ma'am. Even I have a couple of doubt on the same thing. That how can we look into
What
the
if it's
condition?
negative?
Yes, ma'am. Yes,
Mm.
yes.
And
It's
then
fabulous.
still bother, yeah.
Is there any more questions? Okay. So hand over to
Dr. Krishna, are we good? Yeah.
Yes, ma'am. Actually, the vote of thanks is meant to be said by Shalabh Saxena from New Delhi. So I'm hand over to Shalabh.
Yeah. Hi. Thank you so much, Krishna. Thank you so much, ma'am. So it has been such an honor to be a part of this wonderful and insightful event from your end today, and especially on this day, 21st of March today. On behalf of Progenics Lab, I, Shalabh Saxena, would like to extend my heartfelt gratitude to you and to all the participants who have been so patient in the entire webinar. Thank you so much, ma'am, for putting us light on all this entire event.
Thank you. Thank you
Thanks
all.
a lot, ma'am. Thank you so much.
Thank you, ma'am. As Progenics organized hosting the event, Progenics is like genomic solutions, diagnostic laboratories. We are very fortunate that they are just initiated these kind of things that to shed awareness, webinars and campaigns or rare disorders and as such chromosomal abnormalities. And as being the expertise like you, just shedding light on those things that actually make us a complete awareness and as such as detailed recent cases and forward the policy making changes and all from your experience and from your the cases what you have seen have a different perspective on this. So all those things made us to learn to make our own curriculum to be better explanation of the disorders. Thank you so much, ma'am. Thank you for coming.
Thank you,
And
Krishna. Thank you, Doctor.
Thank you, audience, and we are good to close. Thank you so much.